interventional radiologist, so we are very happy that you are here. Trained in Oxford, I saw.
That's correct.
But make the step to come to London and work here in London, so it's a home game for you.
Our home is literally 5 minutes walk.
Yes, I know. It's very nearby.
Very easy.
Oh, you're home now. You're home now.
Oh no, home for work. Okay, so it was really good to hear what the previous two speakers had to say about what I'm going to talk about, and hopefully I'll echo what you've said. Hopefully I won't say too much controversy. I would completely agree about what's been said already. The classifications are confusing. They're numerous. The same lesions are talked about in slightly different ways in different papers, making it seem that they're different entities, but in fact they are the same entity. And I kind of use this in my own head. So the spinal avian malformation, where there's an abnormal tangle of vessels with a nidus, be intramedullary or intra and extramedullary, the sort of Cobb syndrome. The extramedullary ones are very, very, very rare. I would agree with the sort of classification in terms of numbers. The intramedullaries are more common, but by far and away the most common type of lesions that present to us are the dural avifistulas, where there's direct connections between the arteries and veins without any intervening nidus. Be on the dural, on the nerve root sheath, as we've seen several examples already. Perimedullary around the cord itself, from the AC, anterospinal or posterior contributors, or epidural. The last two are very rare indeed. So a lot has been said. I've borrowed Spetz's pictures as other presenters have. Oh, what's that? Okay, fine. So I've borrowed Spetz's pictures others had. I'm not going to say much more about that. I'll confine this talk to areas of novel interest. This is a patient with typical cord syndrome, a few little dots of vessels behind the cord, both on the T2 and also high resolution cysts. As a radiologist, I might use different terms, but show the same things. And the typical angiogram at the segmental artery with the feeding vessel going towards the shunting zone on the nerve root sheath with the intradural drainage around the cord, looking very impressive. And so from an endovascular point of view, and I'm going to confine my talk mainly to talking about endovascular things, the goal of treatment is to get a microcatheter up there, get a microcatheter as close as possible to the abnormality, and inject glue would be in my preference, although some operators do use onyx, and I'll come to that maybe in the coming slides. But glue with the aim that you, from your position you get to, and of course there's a limit to the technology here. You can never know. You very rarely get all the way to the fistula. You're always a little bit separated from it, and therefore you have to mix the glue up into the right concentration, usually fairly weak, and inject it. And there's a little bit of luck at that point that the glue goes forward enough, and hopefully goes forward all the way through the fistulous point and into the draining vein by a short section, although in this case by quite a significant section. And by doing that, and only doing that, can you be sure that you've actually done enough to probably, how many words are used there, occlude the fistula. I think you showed some of these. So this is a slide just showing that there is a recurrence rate. And I agree exactly, and I think these numbers are roughly what you were showing. You showed some of these, you showed probably more than this actually in your talk. But certainly some of the names of the papers are the same. And so the recurrence rate is undoubtedly there and higher for endovascular versus surgical. I completely agree with that. And the key is, from our point of view, is reaching the vein. When you do a proximal occlusion, there's always a chance that new dural vessels can grow in, and the fistula carries on, or it comes from another level below or the opposite side. So reaching the vein is the goal. Clearly, as also has been mentioned, we're put off if the anterospinal or posterior or main posterior contributions come off from the same level, or even sometimes the level above and below, because when you're injecting glue or onyx, there's a little element of uncontrollability to it. You can't really guarantee that it only goes forward in the direction you want it to go, and sometimes it goes in other directions. In terms of that, glue is great because it's very pro-thrombotic. By injecting a little bit, even a drop in the right direction, it allows thrombus to take place and allows clots to form, and thereby allowing a suboptimally closed vessel to close. Onyx doesn't it's non-adhesive and isn't so as thrombogenic, and so it can often layer in the vessel. And if you don't do an adequate job, if the vessel blocks and you can't get any more catheter blocks, you can't get any more forward, you can lead to a situation where it will come back, and that leads to a slightly higher rate of recurrence with the onyx. The other problem about the onyx is you build up a lot of pressure in it, and it can head in lots of different directions over the course of about a 20-minute injection, some of which you can see and some of which you can't see, and that aspect to it gives you a bit of danger in the cord where there might be more vascular supplies to the cord. So moving on to cord AVMs, you've said all this. The previous two speakers have shown these things very much. All I would say is they're always supplied by ASA or PSA, antrospinal or post-spinal contributors, with a nidus, either diffuse or compact, as we've heard. And this is one which we did treat endovascularly, very similar to one of the talks, one that presented with high cervical cord lesions throughout the entire aspect of the cord, some signal change in the cord above and below, and some obvious varicosities or arterial aneurysms in the nidus itself. This is supplied, this is one we did in an adult, supplied by antrospinal artery from above, and that's the flow. Hopefully this is demonstrating quite nicely. I've got no MAC issues in this case. Injecting the vertebral artery on the other side. Again, it's filling a slightly different component of the nidus. This has got more of the varicosity of arterialized aneurysms at the base of the nidus that I showed on the MR, and that's filling from the other side, indicating that it's very important to be very meticulous in the angiography. I've moved the projection here, but keeping the projection as similar as possible and injecting all the arteries so you can add up which vessel is going where and very clearly define which is the antrospinal, which is post-spinal contributions, where the antrospinal axis might be above and below. This was treated with a couple of glue injections. This is one of them. The key here is to get the catheter off the antrospinal axis. We feel then it's safe, hopefully into a sulcal artery penetrating into the nidus itself. And therefore injecting glue away from the artery you're most interested in, but being in the artery you're most interested in as well. So very delicate, very difficult and dangerous embolizations, which we don't do very often, I've got to say, partly for that reason. And this is the end result. Very difficult to completely exclude these angiographically as well. And this patient went on to have a few subsequent treatments, but we're still left with a residual. So where does this prognosis, poor prognosis of spinal cord AVM, you did mention it in your talk, I wonder whether part of what we're talking about is very historical, and this is two papers where maybe some of the data of saying where the overall poor prognosis in AVMs and spinal cord present came from. They're very old papers, 1994, 1974, 1978, but horrendous numbers, which I'm not sure we see in terms of our own cohort. I agree these lesions present rarely, but the patients that do present to us can sometimes do very well. And in my own experience and our experience in our practice, both at the National Hospital, we see the adults, and the Children's Hospital Great Ormond Street, we have very few that deteriorate. So, for instance, this is a boy now 4 years ago. He presented with a little hematoma in his cord. You can see the T1, sagittal T1 weighted image, this little bright area within the cord hematoma. A lot of it cord edema as well. Clearly, you can also see the nidus. That's the axial. The angiogram, this is the antrospinal axis coming off the vertebral basal junction, and just below that, this is actually a post-spinal artery, and you can see that in the lateral. As I've injected the antrospinal axis here, pop the catheter in, and in order to treat this, I'd want to get into the nidus, so come off the main axis and into the main nidus itself, and be injecting glue away from the anterospinal axis. So if glue did come back, I'd have an element of time before it blocked the main artery. So this is some lateral projection. This is the AP injection, and you can see the little feelers going up into the sulcus and up into the nidus itself, and they're the ones we want to get into, those little hooped sulcal arteries. And just to prove it from the back, I've kept the projections exactly the same. So this is the post-spinal axis, post-spinal artery that goes on to supply the AVM, and you can see it wrapping around the back of the cord, coming in at the side. Much safer to treat, and if I needed to do anything, I'd prefer to do it from this artery than from the other. But we did nothing in this one, partly because we saw no nidal aneurysms, and partly because we were concerned about causing damage to the eloquent arteries. And the child has done very well indeed. Now 4 years out, all the edema is resolved, the AVM continues to be treated, he's not bled again, he's back to performing excellently at school, doing all the sports he wants to do, except the one that we don't want him to do, which I think is karate or some other such thing. I'm not going to talk at all about surgical resection, it's been nicely covered, but I think I agree in this slide to what you talked about a little bit. I've mentioned already about the embolic materials. Glue would be my preference. Onyx would not be my preference, although some operators swear by it. Particles, occasionally people talk about particles, I think it's lunacy, so we wouldn't use any of those, as I put it very small. I'll show, you talked about a conus AVM. That's just one image of one being supplied by the NSpine axis, and there are a few varicosities again, which was treated acutely by endovascular techniques. I don't know why the surgeons weren't keen, but maybe that's why you were talking about it a few minutes ago. Maybe that's the reason why they weren't keen. Difficult for you to get to. Just in coming few remaining slides, I'm going to talk about large perimedullary AV fistulas. In terms of the George Radesh classification, so it talks about these being macro giant things or quite small. The association with RASA1 mutations and HHT is there with the giant macro fistulas presenting in young adults and childhood. And these often have a lot of mass effect on the cord and give a lot of venous hypertension as well sometimes as well, but often it's the mass effect is why they present. This is a microfistula near the conus, which was treated operatively, but actually came back. Oh, touche. So it was treated operatively. It's the anterospinal artery coming down, and if I just run through, you can see there's a little waist here, and this is where the surgical clips are. And it somehow managed to revascularize itself past the clip, maybe with a little reach of collaterals, down to supply the fistula again, and then getting to the point of fistulation and then the draining veins heading superiorly. And although I haven't shown it on these slides, that's the same magged up image of the same thing. This is a little surgical clip just here. Although I haven't shown it for the slides, if you inject the other segmental arteries that supply going round the conus basket and up again through posterospinal contributors, round the conus basket, back up again to the same fistulous point. We did try and treat this, although George Radesh, who's a big interventionist, was shocked by this. We got to about here and we thought, well, we'll put a little glue in, and we did put a little glue in, and it got whisked away very quickly into the vein and was never seen again. So we got chicken there and we left it to surgical resection. The surgeons went in and reoperated successfully. So that's a microfistula around the phylum, and this is a macrofistula in a patient, sorry, with this big leg. He's got one of these Klippel-Trenaunay-Weber syndromes, Parkes-Weber syndrome, one of these sort of cutaneous vascular malformations, and it's associated with high flow, large macrofistula around the cord. And this is what he has just here in the sort of lower thoracic region. That was detected incidentally. He hadn't been compromised by this. He was having scanning, having surgery to his leg in the near future. And on the lower image, on the scanogram, they could just see some vascular flow voids in the lower lumbar spine, which turned out to be the draining veins. So this was treated endovascularly by us at Gosh. And this is his image. This is his first angiogram. I forget which level this is, T8 or something like that. Hugely hypertrophied artery. You can just make out the superior projection of the anterospinal axis as it goes upwards to supply the rest of the cord. And as it comes downwards, it's enormous, and coming round into the venous sac and then up into the veins in all directions. And the issue here is working out where is a safe place to coil or glue or whatever modality you're going to use, because it's very hard to know where the anterospinal axis continues inferiorly to that sac. So it's a bit of guesswork. By the time you've got a few coils in, and we use coils because they're easy to control, glue in this scenario is a little bit of risk. With such high flow, you're not plugged or wedged in the artery, it can get whisked away very quickly, or you can inject too fast and you'll be up into the anterospinal axis. So we use coils to slowly occlude the fistula. And then, halfway through the coiling, you can actually then identify the anterspinal axis, which continues down below. And so we probably know that it's probably safe to coil all the way back to the point where the anterspinal axis comes off. And so that's the hugely distorted sulcal artery, which is all twisted and turned as the cord itself is off midline too by the big varix. So much clearer at the end. This is now 4 years or 3 years afterwards. You can see there's still a little bit of size discrepancy between the anterspinal axis above and below the feeding segmental artery. And that's because although I haven't shown it here, I've been a bit kind to myself, there's a little bit of fistula flow still, but nothing that we're going to treat. This is a boy with HHT who was having scanning for a third nerve palsy, and they detected, sort of abnormal midbrain, they detected some flow voids in the upper cervical spine. It was us that wondered whether he had skin lesions typical of the HHT, and therefore made the diagnosis. Angiographically, he's got supply from both vertebral arteries. Again, it's identifying where the anterspinal axis is. There's a plethora of vessels, and it points to the way they communicate. And I point to this side on the left-hand side here, the supply on the left, there's a flow void here, and that vessel is the same as this one. So I think from that point downwards, probably the anterspinal axis. Again, it's identifying where the safe place to coil is. It drains towards the brain. He's got nasty lesions in his lungs as well. And I treated this with coils, and this is the position of coiling at the end with reconstitution of the supply from above and below, and very little flow into the fistula. A nice finding that you know when you've seen this, you haven't caused any major problem to the main anterspinal axis. I keep mentioning that word because we're always very worried about it. He's now about 3 years out again. He's doing very well. We see about 2 or 3 of these a year at Great Ormond Street. So yeah, a bit about the natural history, only to say they can gradually deteriorate. I mean, we treat them all when they present because of that worry, so none are untreated. I don't know why that slide's blank. I would say about MRDSA, so this image here on the right is us trying to do some MRDSA, and we use this nicely to identify those feeding arteries rather than contrast enhanced MRA. You can just see here it's coming in a little bit of flashing of the vessels here, and so we know roughly where to start looking on the angiogram. I agree entirely, using modern techniques does help limit the contrast dose and the radiation exposure to the radiologist and to the patient. And this is an epidural AVF, one which drains heads into the epidural venous plexus, and then there's a very small, very fine intradural venous drainage, which you just see coming up here. So epidural venous plexus fills, and then there's intradural venous drainage here, and that's giving rise to the patient's symptoms. You can just make out that vein. This is treated by glue, and this is the final the MRDSA in terms of follow-up, showing it stopped. It stopped. Anyway, it showed that it's no longer there. Final 1 or 2 slides about Cobb syndrome. We rarely treat these. I've not done any stereotactic radiosurgery for it. There was a nice review in AJNR a couple of years ago demonstrating that we should try and treat them sometimes in a palliative method. When they have presented to us, we've left them well alone. I think they're very difficult to treat, hazardous and complicated to understand. But maybe stereotactic radiosurgery is the way forward for them. We haven't done any of that. So I'll leave it there, only to say that from my point of view, very careful, meticulous anatomy. Meticulous angiography is very helpful, very important from my point of view, but it's also very important from your point of view. I would say that if I ever found that my situation that I wasn't going to treat a dural fistula, and we'd probably treat about half the ones endovascularly and leave half for the surgeon, we would leave a coil in at the segmental artery that it's supplied that it is at operatively, not necessarily that it's supplied from, but it is at, to make it easier to identify at the time of surgery, because they all have segmental problems, segmentation problems. Thank you very much.
Very nice talk. Thank you
Now,
very much.
is that controversial?
So that's time for discussion now. Or do you all agree?
I have a question. Sorry. Just we check a lot of brain neurophysiology, and those patients after treatment, even after they had increasing headache because of that. Is it the same for spinal treatments or not?
No.
I have this impression it's not the same.
Not.
Because the pathology is just irritation of neura.
Well, is that endovascular treatment or
Endovascular.
I think it's the onyx, and you push the onyx hard, blocking lots of dural arteries, and also the lesions pressing straight on that dura as well. But in terms of the volume, using hardly any here at all, hardly any. Even the children with large venous varices that were coiling off, pain is not a big factor.
Thank you.
How many days do you keep this patient in after you had the embolization of inpatient? Fistula, for example.
Of an adult type.
Yeah. Day case, or you keep them?
A couple of days.
You keep it. You don't do it last day case, though.
Yeah, no, we wouldn't do the day case. The kids with bigger shunts, we would leave them for longer, often having heparin, because we don't want the venous channels to close too quickly, or the arterialized, or the big arterialized channels which you shut off dramatically to shut down too quickly. So we often leave those macrofistula in for something like a week or thereabouts, teach them to do delta parin at home, low metric rate heparin. Off they go for about 6 weeks of low metric rate heparin at home.
How many of these cases do you see each year?
Of the perimedullary fistulas, about 2, something like that, 3 sometimes.
Okay.
They're
So
rare.
send out the whole area to this hospital?
Yeah. So we at Great Ormond Street, there are places in the world, in the country that do, a little bit of peds, but they probably send all these complex things to us.
Yeah.
Yeah. So we sort of see a lot, big cohort of pediatric work. That's pretty simple.
We recently had a discussion in the section for vascular or these kind of treatments to do on combined treatment. Now it's also instructing like the hybrid OR.
Yes.
So you can do we are now trying to together we're trying to plan stuff to do a combination of treatment.
Yeah.
What's your idea for
Love that. We've talked about it a lot with our keen surgeons who we now have on board in our neurovascular team, and we haven't yet done it. But you're talking about spinal things, or you're talking about cerebral things?
Now it's spinal.
Yeah.
Like we actually doing it for both, but I think actually because most of it is focused on complex, because we're now constructing one hybrid OR, which is also will include more for the cranial part. But I think in the end, perhaps also because not only for localization, for many things, I think for spine, it's also should be quite added value to do combination.
Yeah, I completely agree about the. I mentioned just in one thing about these patients would really benefit.
Yeah.
Because once you coil that sac off, that sac does swell slightly. The cord's already compromised, not in this boy, but the one we did a couple of months ago. This cord is already compromised, and that little bit of swelling, which you can't detect from MR, causes them to deteriorate in 2 or 3 days' time, and that's when a combined approach would be really useful to operate at the same time, and even just to do a decompression laminectomy.
Yeah, or even like localizing, which you showed a nice example for the XA. You can with surgery you can really easily see, for example.
Yeah.
Or to combine it also for, of course, we now at first we're only thinking of like using balloons for complex aneurysm in the brain, but also for spine. You can, it will not be often. It's also through integration. You see that the rest of your radiologist colleagues do quite often with the vascular surgeons.
Yes.
I think for neurosurgeons also quite added value.
Yeah.
I think we had a discussion years ago with Lajonios when he was still living.
Yeah.
He was training one of our radiologists, and we had some huge C-spine problems, and he said, well, it's too risky to treat because of the swelling. And then we already discussed about the hybrid OR, and I think it's some 20 years ago, and it's still not here. So
And they're starting now.
This
autumn.
It's very professional.
Yeah, no,
Okay.
we will do some.
Thank you very much. And
Small but very good discussion.
yeah, then I heard that it will be on live stream, and this morning was also a small group, and 700 people already looked at the presentations around the world. So thank you very much, Adam.
Well, I hope George Rennie and all our colleagues hope we've set the right table on that
Thank you very much. And we conclude the session. Very good. Thank you very much.
Thank you. Nice to meet you. Nice to meet you. See you. You face the name.
So you know, Marius Poitsene, he's
Yeah,
he used to work with you?
yeah, we trained him. Yeah, he's great. I saw him just on Friday actually.